So in this session today, Dr. John Paulin will give his presentation and then he will answer any questions you may have. You can add your questions to the Q&A function that you should see on your screen. You can do that as we go along or after Dr. John Paulin has given his presentation. Do bear in mind it is a public forum, so please do keep your questions more general, not too specific. So I'm sure that for many of you, Dr. John Paulin will need no introduction, but it is my pleasure to introduce him today as our expert speaker. Dr. Paulin is a consultant rheumatologist at the Royal National Hospital for Rheumatic Diseases and is also a senior lecturer in the Department of Pharmacy and Pharmacology at the University of Bath. So, Dr. John, thank you for your time today, and I'll hand over to you.
Well, firstly, thank you for inviting me to talk about my favourite subject, which is Raynaud's phenomenon, and specifically what is Raynaud's phenomenon. And many of the people on the call, and I'm delighted to see over 100 people who've joined the call today, will know far more about Raynaud's phenomenon than I do and will ever know from their own personal experiences or from the experiences of loved ones. But what I'll try to do in the next 20 minutes or so is really unpick the different types of Raynaud's phenomenon and specifically really with a focus on primary Raynaud's phenomenon, because I think this is an area that's been perhaps oversimplified and neglected somewhat in terms of primary research. And I think it's possibly an area that's far more complex than we've really given it credit for in the past. And also talk briefly about the scleroderma, the Raynaud's phenomenon that we see in scleroderma and other conditions. So this is Maurice Raynaud himself, who over 150 years ago described the condition that is that bears his name eponymously, and he described 25 cases. And the one thing that all of these cases had in common is that they all had evidence of digital vascular abnormalities. And what I mean by that is the digits or the fingers had problems when it came to the vascular supply of blood to the ends of the fingers. And the very first case he described was a young lady who, under the influence of a very moderate cold, even during summer, sees her fingers become exsanguine, so lose all the blood, become insensible or numb, and of a whitish yellow colour. And this phenomenon happens often without reason, lasts a variable time, and often when the blood flow returns to the fingers, it can be quite painful as the blood flows back into the fingers. And this is as good a description of what most people would consider as primary Raynaud's as you can come up with. I think anyone on this call who has a diagnosis of primary Raynaud's or who's experienced Raynaud's phenomenon will be familiar with this description. Now, Raynaud, one of his other cases was almost certainly a case of systemic sclerosis. And this chap, Thomas Barlow, translated Maurice Raynaud's original thesis from French into English, and he started hunting his own around his own hospital for cases that he felt might fit with this description that Maurice Raynaud had described. And he described a woman who for 5 years during the winter had developed hard yellowish patches on her fingers. But unlike that first case, her fingers were permanently altered in that the extremities, the fingers became cold, hard to touch, numb and shortened. And the fingers were contracted in a flexed position. And the patient had occasional crises during which the finger reddened and became painful. The end of the finger ulcerated, and this took a long time to heal, often leaving areas of damage. So anybody with systemic sclerosis will be very familiar with this description. So this is Raynaud's plus, really, because this is somebody who's experiencing Raynaud symptoms, but has also experienced these digital ulcers. And over half of people with systemic sclerosis, sadly, will experience a digital ulcer at some stage during their disease course. And this, again, description from 130 years ago really perfectly encapsulates some of the issues that occur when people experience digital ulcers. There was another case that Maurice Raynaud described, which I hope nobody on the today's webinar has experienced anything similar to this, but this was a young woman who she was nearly 21 when she presented herself to the academy, but when she'd been 7 years old, she'd had a fever, and both her hands and forearms had become gangrenous and had withered away, was the description used, to the commencement of the elbow. So this tragic case is somebody who had poor blood supply to the hands and fingers that was so severe that the limbs became gangrenous. And this is a case that we wouldn't now consider as having Raynaud's phenomenon. I don't think any physician today would call this simple Raynaud's phenomenon, because this is clearly something more catastrophic has occurred to lead to this, perhaps a form of meningitis, for example. But we wouldn't really use the term Raynaud's. But I think why these three cases that were all presented around the time of Raynaud's life are important is because they demonstrate to us how this term Raynaud's phenomenon has come to be used to describe a very wide range of different types of clinical presentation, which includes people with a benign but intrusive vasospastic disorder, what we would consider primary Raynaud's, and people with Raynaud's symptoms that are being caused by an underlying health condition that can be far more serious, such as systemic sclerosis. So what is Raynaud's phenomenon? And there were clinicians in the early 20th century who really sat down and tried to get to grips with this particular issue. And they asked this question: should the diagnosis be reserved for a carefully defined condition, or should its boundaries be so extended as to include the larger and more inclusive group of vasospastic disturbances? And what this really gets to the heart to is my last point. Should we only be using the term Raynaud's for a very small group of people, perhaps people with systemic sclerosis or people with primary Raynaud's, or should we use the term Raynaud's to describe any form of condition in which the blood supply to the fingers is influenced by cold and leading to these attacks where the fingers change color and lose their sensation? And I think even nearly 100 years on, we haven't really fully answered that question. We've drifted into a scenario where we do use the term Raynaud's phenomenon to describe these diverse groups of conditions. And I would argue that that actually can present problems in terms of misdiagnosis and diagnoses of significant diseases such as systemic sclerosis being delayed because people sometimes are falsely reassured that their symptoms are just Raynaud's. And in terms of what is Raynaud's, and again, many of the people who've joined the webinar this evening will be far more familiar with these experiences than myself, but the fingers often, in response to cold exposure or emotional stress, the blood supply to the fingers will become impaired. Now, this can lead to the fingers turning different colors, and one of the commonest colors is white, which is where the blood supply to the fingers gets abruptly cut off. And there's images here that show this blanching or whitening of the skin. Sometimes if the blood in the fingers then gets caught and can't adequately clear from the fingers, the blood loses its oxygen. And when blood loses oxygen, it goes from red to a blue color, which leads to this blue discoloration of the fingers. The medical term for that is cyanosis. And this is trapped blood within the skin of the fingers, losing its oxygen as it gets used up by the local tissues. And as Maurice Raynaud described, sometimes after this initial period of vasoconstriction or narrowing of the blood vessels, you can enter a phase of the condition where too much blood flows into the fingers to try and bring more oxygen and nutrients down to the skin of the fingers, and this can make the fingers become very red. And sometimes that can be the most painful part of the syndrome itself. So as I've mentioned, the symptoms are typically triggered by cold exposure. If people come along to my clinic and say, I never get episodes of these symptoms in response to cold, then I automatically start thinking, well, what else could this be other than typical Raynaud's? So cold exposure is usually an important trigger. Emotional stress is an important trigger in both primary and secondary forms of Raynaud's, and I'll explain in a second what I mean by that in more detail. But it seems that emotional stress seems to be a particularly important trigger in primary Raynaud's phenomenon, which is the commonest form of the condition. Doctors are always interested in color changes, and we diagnose Raynaud's often based on a history of cold sensitivity and changes in colors of the fingers. But actually, patients, when you ask patients what are the most important symptoms for you, the top three are usually pain, numbness, tingling or burning in the fingers, these sensory symptoms which occur when the blood supply to the fingers is impaired, and then an inability to use the fingers. So I can't get coins out my purse, I can't get dressed properly, do the things I need to do because of these Raynaud's symptoms. And these are the main physical symptoms of Raynaud's phenomenon. But we did a piece of work a few years ago to really look very broadly at the patient's experience of Raynaud's, and it came to our attention that patients actually, there's an important emotional impact of Raynaud's. It can cause severe frustration with not being able to do the things you need to do, body image dissatisfaction and embarrassment from the fingers changing colors. This can be a particular issue if people are giving an important presentation at work and that emotional stress leads to Raynaud's symptoms and their fingers changing color whilst they're in the middle of a presentation. And unsurprisingly, this can cause a certain degree of irritation and anger, particularly if you're having to seek help from other people to do the things you want to do. And these Raynaud's symptoms can impact on your daily plans, both in terms of work participation, but also participating in sport outdoors. And the concern is that this could lead to social isolation and an overall reduced quality of life and concerns for the future. And I think this is certainly an issue in systemic sclerosis, where many patients will report that when their Raynaud's is severe, they start worrying, particularly if they've had an ulcer in the past, am I going to have another ulcer? Is this a sign that the disease is somehow progressing or getting worse? And I think that's a very understandable response to these intrusive and worrying symptoms. So in terms of types of Raynaud's, I've touched on this already, but by far the commonest form of Raynaud's phenomenon is what we would call primary Raynaud's phenomenon. And by that we mean there's no known associated condition driving the disease. And this is extremely common. It affects about 1 in 10 of the general population. It's far more common in ladies than men, probably about 4 times more common in women than men. And I think that reflects the important role of female sex hormones in contributing to the size of the blood vessels supplying blood to our fingers. And this is something we know about because often ladies at the time of their menopause will notice that the blood vessels open up and cause them hot flushes. So these sex hormones do seem to exert an effect on the blood vessels that make them want to be more responsive to cold and clamp down more readily. And then there are the other conditions, the underlying conditions that can lead to Raynaud's symptoms. And this can be hormone problems like thyroid disorders. It can be vascular compression, so having a cervical rib, an extra rib that's pressing on the blood vessels, supplying the blood to the hands. This is often in the vascular cause. When vascular compression is the issue, the symptoms might just affect one side of the body rather than both. It could be an underlying blood disorder, and there's a number of different abnormalities of the blood that can make the blood more sticky and want to clog up the blood vessels, and that can actually lead to a reduced flow of blood down to the fingers. Certain medications can aggravate this problem and unmask Raynaud's, a common form being beta blockers, which are a commonly used medication used in people who've had heart problems, maybe after a heart attack, or people with fast heart rhythms, or people with heart failure are often put on a beta blocker, and sometimes this can precipitate Raynaud's symptoms later on in life. Sometimes people who've received medications for certain forms of cancer that unfortunately the medications themselves appear in some people to cause damage to the inner lining of the blood vessels that can set off Raynaud's-like symptoms. And cancer itself actually can be a cause of Raynaud's symptoms in some people. In other patients, nerve damage, and a very common cause of this is when the nerve in the wrist, the median nerve, gets pressed, and this is because our nerves ultimately feed information to our blood vessels that determine the blood vessel size. So if the nerves are being irritated or squashed, this can actually lead to Raynaud's-like symptoms. Again, that's often a scenario where the symptoms may just affect one side of the body instead of both. And then, certainly from my perspective, the most important group of conditions that can lead to secondary Raynaud's are the autoimmune rheumatic diseases. And thankfully, these are very rare diseases, but they can be serious. And so systemic sclerosis, for example, affects about 1 in 5,000 people, so, or 200 people per million. So when you compare that to primary Raynaud's, which affects 1 in 10 of the general population, you can see that these are by far the rarer group of people, but they're the group that we want to pick up on as early as possible. So what are the features that increase the likelihood of somebody having secondary Raynaud's? Developing Raynaud's symptoms late on in life, over the age of 30, is obviously a concern. Most primary Raynaud's will occur in late adolescence or early adulthood. There are certain features within the skin that can also be a concerning feature. So if people have noticed that the fingers have become more puffy, and they may notice that their wedding ring has become more difficult to get off. And certainly in systemic sclerosis, this can occur many years before people develop actual tightening of the skin of the fingers. The development of sores or damage to the ends of the fingers as a result of the poor blood supply. And then gastroesophageal reflux disease or heartburn, that's another very common symptom in systemic sclerosis. So I'll always ask patients in the Raynaud's clinic, are you getting any reflux? When did these symptoms start? I've mentioned already that there are certain vascular causes and neurological causes of Raynaud's, which will often affect just one side of the body. So if people say, I only get symptoms in one hand, that will automatically make me consider or want to seek an explanation within the nerves or blood vessels within that limb that could explain that. And then we do basic laboratory tests on everybody with Raynaud's symptoms, and some of the blood disorders that we talked about earlier that can cause Raynaud's, it will become evident on their blood count that there's an issue there that needs to be addressed. So when you look at the overall picture of Raynaud's phenomenon in terms of the community picture, primary Raynaud's is by far the bigger issue. This is the condition affecting 1 in 10 people, and secondary Raynaud's is this much smaller group of conditions. Probably, I think the best guesstimate of how many people overall have secondary Raynaud's might be around 1 in 1,000, but this really is a guesstimate because it's, as I've mentioned, this is a secondary Raynaud's is an umbrella term that really describes lots of different disorders. The autoimmune rheumatic diseases causing Raynaud's is probably about 1 in 3,000 people. And as I mentioned in the last slide, people with systemic sclerosis is 1 in 5,000 people. And the reason we've ended up using the term Raynaud's phenomenon to describe all of these different clinical presentations is because all of these people will experience cold intolerance with color changes of their fingers in response to cold exposure and emotional distress. And they'll also often experience similar levels of pain, numbness, and loss of function. So primary Raynaud's, despite the fact that doctors will often perceive it as more benign, the symptoms can be as severe as people with scleroderma-related Raynaud's in terms of the severity of the digital vascular symptoms. The experience of the rheumatology setting is slightly different. When you look at the patients who come through a Raynaud's clinic in a rheumatology unit, about half of patients will have primary Raynaud's and the other half will have secondary Raynaud's. And this is because it's a very carefully selected group of patients where GPs have only referred people in if they've really been concerned that people have secondary Raynaud's. And I think for that reason, doctors in secondary care and rheumatology units such as our own, when we see primary Raynaud's, we'll often see the more severe end of the spectrum where the referral has been prompted by the GP harbouring concerns that these patients might have an underlying health condition that's driving their disease. And about 30% of the total number of referrals who are referred to ourselves will actually have an underlying autoimmune rheumatic disease. And that's partly because there's often other features present or abnormalities on the blood tests that have prompted the GP to think, could this be an autoimmune rheumatic disease such as scleroderma? So my experience of Raynaud's is very different really to the experience that a primary care physician or a GP would have of this disease. So I've talked already about primary Raynaud's, and I think it's still helpful to just reiterate and these ideas and themes, but definitions: an exaggerated response to stimuli with no known underlying cause. And as I mentioned previously, these conditions are usually emerge in late adolescence or early adulthood. And this has led people to think, well, if this is a group of people who have a primary functional vasospastic disorder, so what I mean by that is there is something that makes their blood vessels more responsive to cold than other people, then it must have a genetic basis. So it must be something that we inherit. And actually, there's almost certainly some truth in this. So we think that heritability may account for about half of all people with primary Raynaud's. So we haven't identified which genes they are yet, but there almost certainly are genes that increase people's likelihood of experiencing primary Raynaud's. And they've proposed a number of potential genes which are involved in the responsiveness and the size of blood vessels, but actually efforts to try and identify which gene in particular is involved haven't yet yielded any results. But what we do know is that even people who have a family member with systemic sclerosis are far more commonly affected by Raynaud's symptoms than people who don't have a family history of an autoimmune rheumatic disease such as scleroderma. So it is possible that some of the heritability in families where there are people with an underlying autoimmune rheumatic disease represents some kind of link with that family history. So I'll give a couple of examples. This is a gentleman in late middle age, non-smoker, and he suddenly developed Raynaud's symptoms. So there's a few red flags there. One is that it's a male, because we know that primary Raynaud's is far more common in females than males. The other is that he's developed symptoms in his 50s, but all of his laboratory tests and antibody testing was normal. And this is his fingers. The top image there shows the blood supply to his fingers under resting conditions. And then we've done a cold challenge, and actually all the images look near identical because the blood supply to his fingers was fairly poor at baseline and didn't really respond in any way to the local application of cold. His nail follicle capillaroscopy wasn't completely normal, but what you can see from these images, for those of you who've never seen images of nail follicle capillaroscopy, is these capillaries, these very small blood vessels at the nail fold, are all a similar size and shape, and there's that they sit like hairpin loops, and they're all a similar distance apart. So a few of them are slightly longer than we might expect to see, but on the whole, this would be considered either a normal study or at best subtle changes, but these aren't the changes we associate with systemic sclerosis. And I know Dr. Herrick or Professor Herrick will be talking more about the investigations we do to investigate Raynaud's phenomenon, and in Professor Herrick's talk, she'll cover in more detail some of these tests. But the other feature of the history here that was relevant is that he'd lost 2 stone in weight, which had actually brought him right down to the bordering on being underweight. And this was planned. It was part of a fitness drive, and he'd also taken up a job in working in a very cold environment. And I think this is the key aspect of the history. So that explained why he developed symptoms or presented at the time he presented. And it reminds us that really humans aren't designed to live as far north in the northern hemisphere as we do, and we've ended up migrating to parts of the world which are ill-suited to our human physiology in terms of maintaining a core temperature. So humans, early humans are thought to have started their migration from this Horn of Africa, where interestingly the ambient temperature during the day would regularly be in the 30s and closely approximate our own core temperatures, but we've ended up living in places like the UK, which can get quite cold during the winter. And we've obviously adapted in many ways in terms of clothing and creating shelters, but our blood vessels and our fingers are still very responsive to the fact that to maintain our core temperature of 37 degrees, they have to clamp down quite hard to prevent excessive heat loss from our fingers. And that closing down or narrowing of the blood vessels in our fingers is a very effective mechanism that our bodies adopt to help maintain our core temperature. So, and it's the blood vessels responsible for this thermoregulation are these what we call arteriovenous anastomoses, and these are these links between the arterioles, which bring blood with oxygen to the ends of our fingers, and the venules that take the blood away from the fingers once that those oxygen and nutrients have been passed on to the fingers. And there's a very large variation in prevalence estimates of primary Raynaud's, and it ranges from only 2% of the population to 22% of the population, and that depends greatly on the population studied. So the study that identified Raynaud's affecting up to a quarter of people in the population was a study undertaken in Scandinavia, specifically in Scandinavian women. And so and obviously this is an area of the world where the wind, certainly during the winter, the temperature can get quite cold. And there was an investigator many years ago undertook a study of lots of different populations in America, Charleston, in the Carolinas, and in various parts of France, and found that when you used questionnaires to determine what percentage of the population had Raynaud's symptoms, it varied greatly between these different geographic groups. And what was interesting is if you look at the mean temperature during January in these groups, you'll find that as the temperature in January gets colder and colder, the prevalence of Raynaud's, the frequency of people experiencing Raynaud's symptoms goes up within those populations. So it reminds us that in some people at least, their Raynaud's symptoms could be a very appropriate thermoregulatory response and a way in which the body helps maintain a normal temperature. And nearly 100 years ago, Allen and Brown, who were investigators who were interested in Raynaud's, they noted that about half of the people attending their Raynaud's clinic were considered underweight. And there's been a number of studies since then that have also shown that the lower your BMI, your body mass index, which is a measure of your weight in relation to your height, the lower that is, the more likely you are to have Raynaud's symptoms. And actually carrying extra weight protects you from Raynaud's phenomenon. You're far less likely to have Raynaud's phenomenon if you're overweight. And this really reminds us that some of these Raynaud's symptoms within people with primary disease relate to our bodies or the efforts our body makes on our behalf to help maintain and conserve our core temperature. But it clearly has an impact on management. And again, Professor Herrick will be talking more about management, but I spend a lot of time with patients talking to them about the importance of maintaining their core temperature. So it's not just about wearing gloves and maintaining the temperature of the fingers, but maintaining the temperature within the core itself. And this has led people to comment that we're all subject to Raynaud's phenomenon to a greater or lesser degree. And some people have even questioned the very existence of primary Raynaud's, saying these are healthy people, but the way their fingers respond to cold is just more obvious and more troublesome than in other people. A more concerning area in primary Raynaud's is could this be some level of hardening of the arteries. And a number of studies now have shown that people with primary Raynaud's phenomenon do appear to have a higher risk of cardiovascular disease. And some estimates suggest that's up to 4 times more common. Others have suggested it's about twice as common. Some of this may be related to the medications they're using. So I mentioned the beta blockers earlier, and smoking is obviously something that will encourage the blood vessels in our fingers to close down and narrow. And this is obviously associated with cardiovascular disease. So there may be other factors at play that lead to this apparent relationship between Raynaud's phenomenon and cardiovascular disease. But one thing we do know is that if you take a Raynaud's clinic, and this is work that's published from an American Raynaud's clinic, they found that hardening of the arteries or atherosclerosis was the only obvious explanation for Raynaud's symptoms in a reasonable proportion of the people attending that clinic. So here's another example. Is this primary Raynaud's phenomenon? So this is a lady who describes increased sensitivity to cold with pain and numbness and discoloration of the fingers. But again, all of the laboratory tests here were normal, and there were no clinical features to suggest a secondary disease. We did thermal imaging studies in this person. Actually, unlike the last case I described, the blood supply to the fingers was excellent, both resting conditions and following cold exposure. Again, the nail fog pleroscopy, a little bit more difficult to actually see the nail fog capillaries, but looked very normal. But the additional information which I think is relevant here is that the patient also had hyperalgesia, which is increased pain sensitivity. They were intolerant not just to cold, but to bright light and loud noise, and they had unrefreshing sleep and widespread pain in their muscles. So these are all the features that we associate with fibromyalgia syndrome. And I think in some people with Raynaud's symptoms, the issue may be cold intolerance, and again that they are the blood vessels are actually behaving quite normally in response to cold, but the symptoms are being amplified as a result of some other factors. And again, this group of people, the management may differ as a result of identifying aspects such as this. So I'm going to stop talking now so that we can start addressing some of your questions. But just to conclude, Raynaud's really is a complex field because we've ended up applying this term Raynaud's phenomenon to describe this huge breadth of conditions and clinical scenarios related to digital vascular abnormalities, related to reduced or impaired circulation to the fingers. Sometimes there's a very clear cause, and in that instance we use the term secondary Raynaud's. And at present, in the absence of an obvious cause or medical condition, we use the term primary Raynaud's. But again, hopefully during this talk I've impressed you my own personal bias that even this primary group of Raynaud's, there may be people who have an inherited disorder, there may be people who have silent hardening of the arteries, there may be other people who there are factors that are where the core temperature is being threatened and the blood vessels are behaving quite reasonably to help conserve their core temperature. So I think even primary Raynaud's is not the straightforward benign vasospastic disorder that sometimes the medical textbooks would have you believe, and actually we need to and should be interrogating this more carefully. What we certainly should ensure is that all people with Raynaud's symptoms are very carefully assessed, and we consider what may be the drivers of Raynaud's symptoms within those people, because then we can make sure that our treatments focus and are tailored on the main factors driving their Raynaud's symptoms. And I say this will be a theme that Professor Herrick will be returning to in her webinar in a few days' time. And with that, I will stop my presentation and let Gemma pick up the thread in terms of questions and answers, which I'll do my best to answer.
Great, thanks, John. That was really fascinating, actually. I learned a lot there, so I hope everyone else is enjoying it. We've had a few questions come in, and actually 2 people have asked, does Raynaud's affect your toes? Yep.
So Raynaud's can affect all of the extremities. So The fingers, I think, are very commonly affected because these are areas of our body that are often exposed to cold, because we have to have our fingers out to use our hands effectively. But the toes can be affected. If people only have Raynaud symptoms in their toes and not their fingers, again, that makes me want to interrogate what the potential reasons for that might be, in terms of hardening of the arteries, for example, which sometimes will affect the lower limbs more than the upper limbs. But yes, it can affect the toes, and other parts of the body it can affect in terms of the extremities are our ears, our nose, and sometimes even the tissue around our nipples can be affected, and that can be, again, a particular problem in females with primary Raynaud's. They can get quite severe pain, and sometimes they're embarrassed to mention that, but that is something that can sometimes occur in Raynaud's. So yes, so it's certainly not just the fingers.
Great. Thank you. We've also had a question from Campbell, who said, I only have symptoms in my left hand for approximately past 10 years. I've used vibrating tools at work for the last 35 years. Can this be a contributing factor?
Yeah, so that's a really good point. So, and actually I didn't mention that. So vibration white finger is almost a condition separate to Raynaud's, but it can present with very similar symptoms to Raynaud's in terms of finger discoloration, pain, numbness. And as the medical term suggests, vibration white finger is usually precipitated by exposure to vibrating tools, and that is an important cause of symptoms affecting only one side of the body. And usually the history will include worsening after using a vibrating tool, and perhaps affecting the hand holding that tool, such as a dentist drill, for example, and improvements on symptoms when that particular activity is avoided. And importantly, this is a group of syndromes where symptoms are often not necessarily precipitated only by cold. So it's an example where one of those key tenets of Raynaud's phenomenon isn't present.
Great, thank you. Question from Mark. Does a change in weight affect the severity of symptoms? I've recently been losing weight and my symptoms have been worse.
There we go. So that has been described. So, and people, they've noticed that there's been publications where people who've had weight loss surgery have developed Raynaud's symptoms after considerable and very rapid weight reduction. And this gets, again, I think this represents that suddenly the body is having to adjust to the reduced weight, and they've lost some of the insulative qualities of fat tissue, which is leading to the body having to tell the blood vessels and the fingers to clamp down to help maintain the core temperature. So, you know, any rapid weight reduction that's been planned could certainly cause these types of symptoms. If that was unplanned, that should be investigated in its own right. But yes, it does appear that weight reduction could aggravate Raynaud's symptoms.
Thank you. Another question. So you mentioned the influence of hormones. Can hormonal contraceptives like the pill or implant affect primary and secondary Raynaud's symptoms?
Yeah. So in terms of the answer is yes and yes. So in primary Raynaud's, again, some of the population-based studies have found that people who take the oral contraceptive pill are more likely to experience Raynaud's symptoms, and that will likely be the direct effect of the estrogens, these female sex hormones within those contraceptive products, affecting the blood vessel size and function. So it may be a reason to consider a non-estrogen containing hormonal contraception or other forms of contraception methods if it's causing very intrusive symptoms. And in terms of secondary Raynaud's, it's exceptionally rare, but there is an underlying autoimmune rheumatic disease that can make the blood more sticky. And again, this is something that we worry about with the oral contraceptive pill. So if you've actually had clots in your lungs or legs and you're on the pill, I mean, almost certainly your GP will be considering taking you off that treatment anyway. But sometimes those types of conditions can, there are medical conditions that can make the blood more sticky, and being on the pill could aggravate that. So,
interesting, thank you. So we've got another question, and actually someone saying thank you for the great talk. That's good. Is there any association with prolonged or increased Raynaud's and numbness actually resulting in nerve damage or overstimulation?
So it hasn't been proven. We sometimes see in people with systemic sclerosis some numbness at the ends of, permanent numbness at the ends of the fingers, and I've often wondered whether that may be driven by very poor blood supply to the soft tissues within the ends of the fingers, causing some nerve damage. But if people are experiencing a loss of permanent numbness, again, that might be a feature that might make me consider a neurological cause of the Raynaud symptoms. So that would need to be carefully investigated to establish what exactly was causing what. And again, if the symptoms were on the one side of the body, that would, increase the likelihood that this could be a nerve problem that's causing some of the symptoms.
Questions keep coming. So, question from Lucy. I've heard that cod liver oil can have benefits to those with Raynaud's. Is this true?
So lots of people ask this in clinic. They ask about non-drug related supplements that they can take to help with their blood supply. We don't know exactly what is likely to be effective and what isn't, because the way we prove that something is effective is by doing a clinical trial, and unfortunately we'll never be able to do the clinical trials for these types of supplement products. Cod liver oil is something that patients have described to me helps, and my other people have tried it and not found it helpful. So my suggestion is, with these types of supplements, if you're under regular medical follow-up, let your doctor know that you're taking supplements, because sometimes they can interact with some of the drugs that we use to manage these conditions and other health problems. But there's a degree of trial and error involved. So try these things. If they help, by all means continue them. If they really have no impact on your symptoms, then possibly stop. The one supplement which has probably attracted the most attention has been ginkgo biloba. So that's one that's freely available to be purchased rather than prescribed, and it's a supplement from a ginkgo biloba tree that some people again find very helpful for their Raynaud symptoms.
Great, thank you. So we've got one quite typical. Have you looked at all into how Raynaud's interacts with long COVID, which also appears to be related to how oxygen is carried around the body? Yeah.
So I think it's too early to draw any conclusions on that, but that will be an area that I'm sure will attract a lot of interest in the future.
Right, thank you. And actually, we've had a few people saying excellent presentation, thank you. And somebody saying that they've had it since they were a child and just wanted to say it really reduces quality of life. So I send my best wishes for all that have it. So that's great. Our community are always very supportive of each other. So that's always nice to hear. Another question from Amanda. Are there any known links between Raynaud's and osteoporosis?
So again, going back to my mention about the low body mass index, that can be associated with osteoporosis. And so there may well be links between people who have Raynaud's because their body mass index is low, also being at risk of weakening of the bones. So we certainly see a very high prevalence or frequency of Raynaud symptoms in people who have eating disorders, and that can be a risk factor. So they may be indirectly linked rather than there's no known direct link between having Raynaud's driving the development of osteoporosis.
Right, great, thank you. Another question, somebody said, I experience Raynaud's in my fingers and toes. Would Raynaud's explain why I wake in the middle of the night with numb legs? Again, that's the type of thing that should be investigated. I'd encourage you, anybody experiencing symptoms like that to visit their GP.
listening to that story would make me want to rule out significant hardening of the arteries, because that can cause pain and numbness at night in the legs. So I'd want to examine the pulses carefully to make sure that the main blood vessels bringing blood down to the feet and toes wasn't impaired in any way.
I think that would probably be the same answer for somebody who said that they get symptoms in their thighs when they're cycling. Is this normal?
And well, when we're cycling, our thighs are exposed to a lot of cold air rushing at them, so that will affect the blood supply to the skin overlying the thighs, and will sometimes be affected with a poor blood supply. So, and again, what you're wearing could be relevant if if you're wearing particular outfits during cycling. So again, something that may need to be looked into. And
another anonymous question: can having narrow width feet be a factor?
That's a good question. I don't think I've been asked that one before. So, yeah, theoretically, I suppose the volume of your foot compared to the surface area might influence the way the blood vessels behave, but that it's not something from a medical perspective that we measure or look for per se when we're investigating people with Raynaud symptoms.
Interesting questions coming in. Another one, another anonymous one: could Raynaud's affect fertility or the chances of a successful pregnancy?
So no, they shouldn't. And so if fertility is a concern, then that should be investigated as a separate issue. And there are medical conditions, some of the secondary medical conditions, and in particular the one I was mentioning briefly, alluded to earlier, which can make the blood more sticky, that can affect the fertility and lead and increase the risk of miscarriages. So if somebody came along to the clinic and reported that they'd had a number of miscarriages and they had Raynaud symptoms, I would be very keen to exclude that particular disorder, which is called antiphospholipid syndrome. But these are very rare disorders, and these are very common conditions. So, the majority of people still who have had perhaps a miscarriage and Raynaud symptoms, the two would be considered not to be linked, and there wouldn't be an underlying health problem. But that's why it's so important to approach every person separately and individually and investigate fully.
Thank you. And we've had two questions that are quite similar. So somebody whose daughter is 11 and then someone whose son is 17. So the 17-year-old son has had primary Raynaud's for 4 years in his hands and feet. Will he grow out of it, or will he have this for the rest of his life?
Yeah, so this clustering of Raynaud's in families does suggest to me there are definitely families where or it appears there are families where there perhaps is a gene that is making the blood vessels more responsive to cold. What they may find is that the symptoms don't completely go away, but other factors may change that lessen the symptoms, and that could be that as he gets older, his body shape changes, and that actually helps with the Raynaud symptoms. It may be that he just gets better at adapting and managing his symptoms, which will lessen the burden of symptoms. Or he may choose to have a trial of a drug treatment to help with his Raynaud symptoms. So I think in women there is certainly, or in some ladies, their primary Raynaud symptoms will improve around the time of the menopause, when their natural estrogen levels fall, and that this encourages the blood vessels to open up somewhat, which can lead to unwanted hot flushes. But I have met ladies who found their Raynaud symptoms have improved around the time of their menopause.
Oh, something to look forward to. So we have a question from Jane, who's interested in the link with fibromyalgia, which she's had since her 30s. Her Raynaud started in her 50s. She's now 60 and overweight. Do you know the percentage of people with fibromyalgia and Raynaud's?
Yeah, so this is an area we've done some research on ourselves, because we were fascinated to meet a number of people with fibromyalgia syndrome who also experience Raynaud symptoms. So the reported frequency varies from study to study depending on how rigorous a definition you apply, but one study suggested that over half of people with fibromyalgia will experience cold sensitivity with their fingers changing color in response to cold. And I think the difference in fibromyalgia, which is a pain amplification syndrome where the brain's pain center becomes hypersensitized, and so all stimuli from the body become hyper sensitized. And so people will sometimes with fibromyalgia will often find that somebody giving them a hug, for example, is painful, and that's obviously something that shouldn't be painful. And I think this harks back to the Sir Jonathan Hutchinson's observation that we all experience Raynaud's to some degree. I think the difference being in fibromyalgia is the pain levels are much higher because of that hypersensitization of the body's pain pathways. But a lot of this is speculative, and we need to do more research in this area to really unpick exactly why people with fibromyalgia have such a high level of Raynaud's symptoms, and there may be other factors at play.
Great, thank you. I think we've probably got time for two more. So firstly, from Anonymous, can alcohol consumption aggravate or trigger Raynaud's attacks?
It's not one of the features that we ask directly about when we meet people with Raynaud's symptoms. People will be familiar with the fact that, in the Alps, there were dogs would carry, tots of brandy to help kind of stranded people. We generally discourage that. So whilst alcohol can make you feel warm, it actually probably has the opposite effect. And if you're at risk of cold exposure, whilst it can lead to some flushing, that could actually be detrimental to your core temperature. So I certainly wouldn't encourage people to use alcohol to try and help their Raynaud's symptoms. And but no, there's no known link, and the advice would be that we should all, limit our alcohol consumption to within safe limits and have alcohol-free evenings each week, and to avoid some of the other long-term risks associated with alcohol.
Yeah, good advice for all of us, I think. So we'll have one last question. Is there any link between Raynaud's and low heart rate?
And low heart rate. So again, as is often been the case with some of these brilliant questions that have come through, there could be a link. And, there is certainly, I mentioned that certain hormone disturbances can be associated with Raynaud's symptoms. And if your thyroid gland is not producing as much thyroxine as it should, that could lead to the emergence of Raynaud's symptoms and a low heart rate. And the other potential link there is the use of beta blockers, which is this group of medications that is often used in people with heart complaints, which does slow down the heart rate and can again precipitate Raynaud's symptoms. So so it's the type of thing that might need to be investigated if that's something that people have experienced.
Great, thank you. And we've had some sort of comments from the questions that you've answered, people saying thank you, and somebody's also said they have narrow feet and secondary Raynaud's, so there you go. Start of a new study, I think. So, and also some of the questions that have come in have been related to sort of management, and we will have another webinar on the 21st of February, which will cover a lot of those questions. So please do join us at that webinar. So thank you so much, Dr. John Pauling, for all of your time, and thanks everyone for those fascinating questions. I'm sure we could have talked all night, but we do have to let you get home at some point. So as I've said, we do have another webinar coming up on the 21st of February at 4 o'clock. So please do join us. Keep a look out on our social media channels for all of the information about how to join that. If you've enjoyed today's webinar and would like to support SRUK, you can do that simply by texting SRUK webinar to 70450, and that's a donation of £5. And we will be sending you a link to a short feedback survey. And your feedback's really important to us and to Dr. John as well, because it's great to know when you've given these presentations, you can't see anyone's reactions, and obviously the questions were stimulating a lot of discussion, but it's useful to know what you thought and what we can do better, and what other webinars you'd like to see in the future. So keep an eye out on your inbox for that. And as I said before, this webinar will be available on our YouTube channel, which is We Are SR UK. And if you want have any other information that you need, please do go to our website, which is sruk.co.uk. So great, thank you so much, Dr. John, and everyone. And it just leaves me to say goodbye and have a good evening, everyone. Thank you.